I think that the greatest challenge right now, if I had to summarize this in one word, would be access. And it's basically the difficulty to access population in need in times of crisis. I think we got some stark example in Syria, in eastern Ghouta today, where in the besieged area we're not able to bring aid in. But we have as well the same, I would say, environment in Yemen, where it's been very, very difficult because of the widespread crisis and again, the physical access. We have difficulty to access population in need, and once we're there, population in need have difficulty to access us because of security reason, because of the fact that there were, I would say, repeated attack on hospitals and ambulances and medical facilities, and it has created, I would say, an environment of fear instead of an environment of healing in medical facilities.
So how do you go about these situations in terms of trying to negotiate the access to these people?
Well, we talk with everybody. That's the bottom line, and it's always been this. You know, we're 47 years old organization, and this is what we deal with. It's talking with everybody, and then making sure that what we bring in the heart of the crisis, it's something that is a response to vital need.
With a presence in 70 countries, you're really a major player in terms of global health and some of the biggest providers of healthcare in the world. You've said in the past that global healthcare is very often commanded by the North according to their interests and what they see as being most important to them. But is it really possible to change this agenda when it's really the money is coming from there, from the North?
Well, that is a tough question. And I believe that it's not because there might be an agenda from the global North that we cannot challenge it. And I think one of the key examples of that we have faced collectively is with Ebola. When Ebola started at the end of December 2013 and was officially, I would say, proved in March 2014, we had 6 months to try to basically convince people that something was happening. It was different from all the other epidemics we had. And the only way to get an upper hand on the epidemic was to collectively fight it together.
You were one of the first to get on the grounds there.
Yeah, with of course the Ministry of Health of each country, and other organizations like the Federation of the Red Cross, just to name a few. But that being said, is the fact that initially nobody could see that much value to go. They didn't feel threatened. It was a country really, really far, 3 countries very far from their, I would say, reality. And all of a sudden, things changed. And what did change was that we were at the end of the summer of 2014, and we started to repatriate cases in the US and some in Europe. And all of a sudden, the crisis was knocking in our backyard, and we had to pay attention. And the reality is, we wish we could do better, but unless people feel, and that is my point, feel a connection, a direct connection, then it's going to be really hard to create attraction. And it's the same thing about the migrant refugee crisis, what we call us in MSF, the forced displacement crisis. You know what? People have been crossing borders for years. In 2011, there were more than 40 million people in forced displacement. Now we climb it up to 65 million, so a few years later on. But the reality is, it's because it became a European issue. People basically coming onto our beaches, washing up on the beaches in Europe, that we say, oh my God, it is our business now. So the thing is I think that we can get people interested if they see that it is as well their issue. And then I'm saying that because I strongly believe, and I'm going to go back to the health issue, is with Ebola, we understood that we are healthy here today because our neighbor is healthy.
A couple of years ago, you took a stance on the high costs of medication and that's set by pharmaceutical companies. You actually, at the time, refused a large donation of medications that were being donated to you by Pfizer. Has anything really changed on that level regarding the cost of medication, in your perspective?
Well, I think that not in I would say, the overarching policy of the cost of medicine, but I think that it has raised, I would say, the consciousness on many aspects about access to medicine, to the fact that our point was saying, we understand your generous gesture of giving us medicine, but the reality, it's not about MSF, but it's about the general population being protected with the vaccine of pneumococcus bacteria, against the pneumococcal bacteria. That is the issue. And we find that donation is not sustainable in the long run. Because once we're going to have run out of medicine, what would happen? And then the amount they were giving us was not covering the world needs. And then again, it goes back to, if you want to make all of us healthier, it depends on making each of us healthier. So a child who is healthy in India or in Ethiopia is basically a child who's going to be healthy in Europe, because you will not have those bacteria moving around. We don't have those cluster of epidemics of measles right now happening, or so these or pneumococcus, depending on which vaccine we're talking about. But that is our fight is the fact that donation is not sustainable. Access to is an issue. And in the past, people thought it was only the low and middle income country who was facing that. And then recently, with the advance of, for example, treatment for hepatitis C, and finding out that Gilead had a drug for 12 weeks that was more than, I think, initially 80,000 for the full treatment, people said, oh my God, we can afford that, even in a high-income country. And all of a sudden, access to medicine became a collective issue to tackle together.
In defending the rights of the developing countries and their health needs, do you see, are there other groups or countries that you find are supporting you strongly in terms of that campaign?
Well, first of all, I don't think we are campaigning per se, but MSF, basically, we speak about the needs of population that we care for in those 17 countries where we are, where we have a total global workforce of 42,000 people. So, and we do have many countries in their own way fighting for healthcare. And I think right now we cannot be oblivious with, although we're not fan of it, of the Sustainable Developmental Goal, the SDG, with the universal health access. And now collectively it became a world goal.
Let's talk a little bit about money. How big is your budget presently?
So we have grown to a total incoming operational budget of 1.5 billion euro on a yearly basis.
And where does the money come from?
So we have the immense privilege of having more than 94% of our budget from private donors. So we have a pool of 6 million regular donors across the world. So extremely, extremely privileged.
And are there particular regions that are more generous than others?
Well, there are places where the fundraising has been more developed, and I think North America, especially the US, is a place where we have, I would say, a big proportion of our funding coming from.
Recently, following the shocking scandals that came out of sexual harassment or sexual abuse by Oxfam, your organization actually came forward in presenting a number of cases of, or accusations that had come up within the organization against some of your employees. How concerned were you in how this may look to your donors and the perception that they may have of the organization?
For me, it's just like, it's not being concerned about our donors, but it's about doing the right thing. And the right thing is to make sure that wherever we are, because we're working with populations that are in precarity, that are vulnerable, is to make sure there is no exploitation, there is no abuse of power. And then we will not allow an environment that is permissive. So we do have zero tolerance on what's going on. Our figures is, last year we had 146, I would say, misconduct complaints. There were about 24 of them, I think they were like sexually misconduct related, and 19 people were basically dismissed from their function. And I think that it reflects some part of the reality, but we do welcome public scrutiny on that topic because it allows us to improve our mechanisms for disclosure and then to make sure that we are creating a safe environment for everybody. And I think it's going to be, I'm a physician and I'm an ER physician, and I remember in the 80s, 90s when we started to have the mechanisms to report medical error. Initially people say, oh my God, medical error. And then we went from 0 medical error to 500 on a yearly basis. And people were shocked. And I said, of course, because now we have the mechanisms to report. Before we didn't know. So what I believe will happen, and this is why I'm taking some of the airtime to explain that, is because we're strengthening our mechanisms, is most likely probably our number will increase. And it will be a good sign because it means that people feel safe. It means that we have the right mechanisms that are confidential and professional, and then we will improve.
Precisely. There's been comments recently that there may have been under-reporting, not only in your organization, but throughout the NGOs. So the other issue that I wanted to talk about was the cooperation and within International Geneva and how much you benefit from that, how much you work with, say, the WHO or other organizations here in Geneva.
We are in dialogue with many organizations on a very frequent basis, and some of them it's very, very regularly. One of the examples will be the International Red Cross Committee, the ICRC. We are in dialogue because we are working in the same, I would say, difficult environment. We share analysis together, we discuss, we challenge each other. So we do that. With the WHO, on many, I would say, aspects, we talk to each other. During the Ebola was, I would say, at all the level of the organization, was at one point almost daily conversation during those times. And now, you know, just right now, there's this week, for example, there's a discussion on the essential diagnostic tool list, and MSF will be part of that. We will contribute and just say, this is our perspective of what we see in the field, hands-on. And I think this is what we bring everywhere we go when we have negotiation or when we have discussion or brainstorming with other organization or entity in Geneva, is we bring that, what I call the perspective of a doer at the front line of crisis.